Vamos a dar unas breves indicaciones sobre el funcionamiento de la plataforma en cuanto a la interpretación simultánea. En esta reunión contaremos con interpretación inglés-español. En la parte inferior, en la barra de funciones, podremos visualizar el botón de interpretación representado por un mundo con las siguientes 4 opciones: apagado, inglés, español y silenciar audio original.
Good afternoon and welcome. We are the technical support team and we are here to give some brief instructions about the operation of the platform in terms of simultaneous interpretation. In this meeting, we will have English-Spanish interpretation. In the lower part of the function bar, we can see the interpretation button represented by a world with the following 4 options: off, English, Spanish, and mute original audio.
Seleccionamos el idioma de nuestra preferencia en el que queramos escuchar. Ahí permanecemos durante toda la reunión. Es importante silenciar el audio original para no escuchar los 2 idiomas al mismo tiempo. ¿Todos han encontrado el botón y seleccionado el idioma?
We select the language of our preference in which we want to listen and speak, and we remain there for the whole meeting. It is important to mute the original audio so as not to hear both languages at the same time. Has everybody found the button and selected their language?
¿Me escuchan todos?
Por favor, es muy importante que todos permanezcan en el idioma que van a escuchar durante toda la reunión para que tengan una mejor experiencia con la interpretación. Es también muy importante no dejar la función de interpretación en off. Nosotros estaremos presentes durante toda la reunión. Cualquier duda o inconveniente con la plataforma y sus funciones, puedes escribirnos de manera privada en el chat a InterRCI y con gusto te brindamos la atención necesaria. Iniciamos.
Okay, thank you, everybody. My name is Arturo Chayet, and we are going to start our monthly academic session, this live webinar. We have a very nice agenda. We have as our invited guest speaker, Liliana Werner, Dr. Liliana Werner from Utah. She's going to present us on what can we learn from laboratorial analysis of explanted IOLs. Then we will have a case presentation by one of our fellows, and this will be followed by a very nice discussion and questions and answers by Dr. Werner.
So, good evening. Sorry.
Yes, hi Liliana. I would like to introduce you.
Perfect.
So thank you for being here with us. It's a really big honor to have you, being you the world expert in this field.
Thank
you. Dr. Werner, she is a full professor of ophthalmology at the University of Utah. She is the co-director of the Intermountain Ocular Research Center at the John Moran Eye Center at the University of Utah. And her curriculum vitae is really huge and extensive. So I'm bringing some of the most relevant features that I saw. One of them, which was very impressive to me, is that she has participated as a author or co-author of over 270 scientific peer-reviewed articles, and she has participated in over 80 books or chapters as an author as well. So she's frequently asked to present on the subject, and she is currently one of the associate editors for the Journal of Cataract and Refractive Surgery, and she's the chair for the Continual Medical Education Advisory Committee for the American Society of Cataract and Refractive Surgery. And very recently, I think last month, she was nominated as one of the top 100 most influential female figures in the world of ophthalmology. I think that's huge. I'm very impressed and very happy that women are becoming very prominent in our field. Congratulations, Liliana. And we will hear her presentation, and we're very happy to have you here. Thank you so much, Liliana.
Thank you so much, Arturo, for this wonderful presentation. And it's really my pleasure to participate to this webinar. And actually, congratulations to you for organizing this webinar series. And I'm very much looking forward to have meetings again when we can all meet in person. But I think in the meantime, these online platforms, they work really well, and we can have a good learning experience from it. So I think my presentation, which I send in advance, will be played, and later we can meet and have some discussions together. Thank you all very much again for this kind invitation. It's a pleasure.
Thank you, Liliana.
Thank you so much for the opportunity to participate to this webinar and present about what we can learn from laboratory analysis of explanted intraocular lenses. I do not have any financial interest to disclose regarding this presentation. We have a laboratory inside of the Moroni Center at the University of Utah, and we specialize in the study of IOLs through laboratorial and in vivo studies. Regarding materials used in the manufacture of IOLs, they can basically be divided into acrylic and silicone. Acrylic lenses can be rigid, manufactured from PMMA, or foldable. Foldable acrylic lenses are usually divided into hydrophobic and hydrophilic according to the water content of the material. All hydrophobic or hydrophilic acrylic materials may have a similar base, but they are not the same. So different acrylic lenses are manufactured from different acrylic materials. The same thing is valid for silicone lenses. There are different generations of silicone materials used in the manufacture of lenses with different properties. For example, different refractive indexes. These two properties can differentiate acrylic materials from silicone materials: the glass transition temperature and the refractive index. Above the glass transition temperature, the polymer exhibits flexible properties, and below this temperature, it remains rigid. Acrylic lenses usually have glass transition temperatures that are close to room temperature, and therefore they unfold slowly in a more controlled manner. This temperature can be considerably lower than the room temperature for silicone lenses, and therefore silicone lenses show a faster unfolding. The refractive index is usually higher with acrylic lenses, so these lenses are usually thinner than silicone lenses for the same refractive power. Standard hydrophobic acrylic lenses usually have water contents that are below 0.5%. However, new hydrophobic acrylic materials with higher water contents became available in the markets since some years, and they are considered to be glistenings-free. We will talk about glistenings a little bit later. Some examples of lenses manufactured from these materials are the Envista from Bausch & Lomb with a water content of approximately 4%, and the Clarion from Alcon with a water content of approximately 1.5%. When we talk about IOL biocompatibility, we can divide it according to uveal and capsular biocompatibility. Regarding uveal biocompatibility, the first thing that happens when we perform cataract surgery with IOL implantation is a disruption of the blood-aqueous barrier with protein adsorption on the IOL surface. This protein adsorption will influence all the subsequent cellular responses on the lens surface with attachment of different cells, including giant cells. In an implantation procedure considered successful, there is generally a degeneration of these cells, which will later detach from the lens surface. The IOL surface will then be covered only by a layer of proteins. There are variations in the intensity and duration of cellular responses according to the material used in the lens manufacture, but studies indicate that, in general, all materials that are currently available generate appropriate responses. Capsular biocompatibility describes the interactions between the IOL and the residual lens epithelial cells inside of the capsular bag after surgery. These cells are responsible for the formation of postoperative anterior capsular opacification, posterior capsular opacification, and interlenticular opacification, which occurs when two lenses are implanted inside of the capsular bag. However, today we will focus on the problem of postoperative IOL opacification. In this review article, published in the JCRS, different causes of IOL opacification were described, which were based on analysis done in our laboratory. Let us discuss about different causes of IOL opacification according to the IOL material, starting with hydrophilic acrylic lenses. These are lenses with water contents usually ranging from 18 to 34%, and the main cause of IOL opacification of these lenses is IOL calcification. Since at least the year 2000, we have been publishing a lot on this postoperative complication, and the articles listed here are just some of the examples. We initially analyzed a large number of cases of lenses explanted because of calcification, which were from these three designs: the HydroView from Bausch & Lomb, the SC60B-OV from Medical Developmental Research, and the AquaSense from Ophthalmic Innovations International. We will discuss a little bit about each one of those. Regarding the HydroView lens, the deposits were found mostly on the IOL surface, as demonstrated here by staining with alizarin red or processing through the Foncossa method, which are both histochemical methods to demonstrate the presence of calcium. On the right, you can see the deposits under scanning electron microscopy, and a surface analysis technique such as energy dispersive X-ray spectroscopy can be coupled to electron microscopy to demonstrate the elemental composition of the deposits. You can see the presence of peaks of calcium and phosphorus in the calcified deposits. With the SC60B-OV lenses, the calcified deposits were mostly within the internal substance of the lens, as you can see here by using the same histochemical and surface analytical methods. The analyses were done by using sagittal cuts passing through the center of the optic of the lens. The degree of opacification with the AquaSense was quite impressive, and calcified deposits were present on the surface and within the substance of the lenses. Once again, surface analytical methods demonstrated the presence of calcium and phosphorus within the deposits. Later, we received many lenses explanted because of postoperative opacification, which were of the memory lens design. With this lens, a thin granularity was usually covering the optical surface of the lens. Once again, the surface analysis confirmed that the composition of the granularity was of calcium and phosphate. In the case of the HydroView lens from Bausch & Lomb, some studies indicated that the problem of postoperative calcification was related to a change in the lens packaging. The new package contained components made of silicon. It is suggested by different studies that the element silicon is associated with calcium in an early stage of calcification. This led us to initiate a study evaluating the possible role of silicon contamination on the process of calcification of other hydrophilic acrylic lenses, such as the memory lens, the SC60BOV, and the Aquasense. In this study, we were able to demonstrate with surface analysis that the concentration of the element silicon was always higher in areas with calcified deposits with these three lenses. The problem of postoperative calcification of hydrophilic acrylic lenses appears to be multifactorial, and various factors, including those listed here, may be involved in different combinations. There are likely other factors which are still unknown. In the meantime, it is very important for ophthalmologists to know how to make the diagnosis of IOL calcification during slit lamp examination. In this article, we described 8 cases where the diagnosis of calcification was not made, and the patients ended up undergoing procedures that were not necessary. For example, YAG laser posterior capsulotomy, which actually makes the explantation procedure of the calcified lens more challenging. Some eyes underwent vitrectomy because a vitreous involvement was suspected. Later, IOL exchange was necessary in any way, and some patients had complications such as endophthalmitis, cystoid macular edema, and retinal detachment. More recently, we described a very specific pattern of IOL calcification of hydrophilic acrylic lenses occurring after surgical procedures using intracameral injections of air or gas, such as the MEC or the SEC. Different hydrophilic acrylic IOL designs were involved in this problem, and they all exhibited an overall round area of calcification on the central part of the anterior surface and subsurface of the optic. This appeared to correspond to the area of the capsulorhexis opening, where the lens material is then in direct contact with the aqueous humor. Later, we observed the occurrence of the same pattern of localized calcification in hydrophilic acrylic lenses after surgeries and procedures performed in the posterior segment. Here, you can observe the same pattern of calcification with a round area of calcified deposits on the anterior surface and subsurface of the optic, corresponding to the opening of the capsulorhexis. This occurred after pars plana vitrectomy and gas tamponade. Again, at the capsulorhexis opening, there is direct contact between the IOL material and the aqueous humor. At the beginning, we thought that this complication was related to the direct contact between the IOL surface and substances such as air, gas, or silicone oil. However, this complication was also observed without the use of vitreous tamponade. Therefore, we believe that there may be a metabolic change in the aqueous humor due to the presence of these substances in the eye. And there is also likely an inflammatory reaction that may be subclinical in these eyes undergoing multiple procedures. We recommend that, in case you have a patient to be operated on for cataracts and you anticipate that a procedure such as the SEC or the MEC will be necessary later, You avoid implantation of hydrophilic acrylic lenses. Some clinical studies demonstrated that this type of calcification may occur in up to 10% of the cases. Different issues may lead to opacification of silicone lenses in the postoperative period, such as surface deposition and opacification due to influx of water in these lenses that are normally highly hydrophobic. Here, we will also discuss about an interesting problem of loss of elasticity of the loop material leading to dislocation. Silicone IOLs may also calcify, but this has been only observed in eyes with asteroid hyalosis. We first described this problem in association with single-piece plate-type silicone lenses. The calcified deposits occur only on the posterior surface of the lens, and they can be at least partially removed with an YAG laser. However, there is usually a reaccumulation of deposits after this procedure. Different studies demonstrated that the main composition of asteroid bodies is calcium and phosphate. Therefore, they represent a continuous supply of calcium or are an indicator of a continuous supply of calcium to the vitreous. Here you can see a plate-type silicone IOL that was explanted because of postoperative opacification. There are YAG laser pits on the optic, which indicates that the laser was used to try to clean the lens surface of the deposits, which are present only on the posterior optic surface. Surface analysis confirmed the presence of the elements calcium and phosphorus in the composition of the deposits. This case was interesting because the patient had bilateral asteroid hyalosis. One eye was implanted with this 3-piece silicone lens, which exhibited calcification on the posterior optic surface and had to be therefore explanted. The other eye was implanted with a hydrophobic acrylic IOL that never calcified. This study is an important one because it described 16 cases of calcification of silicone lenses. They were of different models and made of different silicone materials, including older materials and more modern materials with higher refractive indexes. The pattern of opacification was always the same. Calcification only on the posterior optic surface that could be partially removed with a YAG laser, but with reaccumulation of the deposits after the procedure. Here you can see the types of silicone lenses included in the study. There were 8 different designs from 5 different manufacturers made of 5 different silicone materials. Under each photograph, you can see the refractive index of the material. Here is another case that was analyzed under scanning electron microscopy and energy dispersive X-ray spectroscopy. You can see the peak of silicon, an element that is in the composition of the lens material itself, as well as peaks of calcium and phosphorus, which constitute the main composition of the calcified deposits. The presence of asteroid hyalosis in the eyes in this study was practically confirmed in all of the cases. We also reviewed cases of calcification of hydrophilic acrylic lenses, and we could not find any specific correlation between asteroid hyalosis and calcification. It seems that this phenomenon is really restricted to silicone lenses. It is unclear why the number of cases is relatively small. Maybe there is some underreporting or cases that are not recognized. In any way, implantation of silicone lenses in eyes with asteroid hyalosis can be considered a contraindication. I take this opportunity to remind all of you that if you have patients with retinal issues that may one day require retinal surgery with use of silicone oil, these patients should not be implanted with silicone lenses because there is an irreversible attachment of silicone oil to the surfaces of silicone lenses. Let us talk a little bit about very interesting cases of opacification of 3-piece silicone lenses, which was observed very early postoperatively. These cases came from Brazil. After uneventful surgery, significant optic opacification was observed as early as 7 hours after surgery. The lenses were submitted to our laboratory for analysis, immersed in solution. During examination, as the lenses were drying, the optic opacification decreased until it completely disappeared. The same phenomenon could be observed during examination under light microscopy. The yellow-brownish areas in the optic represented areas of opacification, and as the lenses were drying, the opacification disappeared. In this study, we had to do different analyses, including gas chromatography with mass spectroscopy, to verify if the lenses had absorbed exogenous substances. It turned out that they had absorbed molecules that are typically found in industrial cleaning agents and fumigants, such as terpenes and ketones. Using the serial numbers and with the help of the manufacturer, we figured out that the lenses were stored in the same location in Brazil where fumigation was performed because of cockroaches. After storage in the same location, the lenses were sent to 4 different locations in Brazil, and all of them later presented the same type of early postoperative opacification. We cannot forget that these lenses are sterilized by ethylene oxide gas, and they are placed in semi-permeable packages for that, so other molecules in vapor may penetrate the packages. These cases remind us that we have to be very careful with the environment and conditions used for IOL storage. IOL packages should be removed if storage locations are treated with sprays containing chemical agents. The lenses should be stored in a dry environment at room temperature. I take this opportunity to comment about these very interesting cases related not to the optic material, but to the loop material of 3-piece silicone lenses. The loops can be made of different materials, including the one shown here, the polyimide. Few studies evaluated the long-term biocompatibility of this material. We described 2 cases where there was a spontaneous breakage of the haptics of 3-piece silicone polyimide lenses 12 to 15 years after IOL implantation. There was no sign of degradation of the loop material under scanning electron microscopy. However, there was a loss of elasticity of the material, and only by touching the loops with forceps, further breakage was observed. The spontaneous breakage of the loops in these cases led to IOL dislocation. Further studies are necessary to ascertain long-term biostability of polyimide haptics. A cause of late postoperative opacification of PMMA IOLs is named snowflake degeneration. This happens with 3-piece PMMA IOLs manufactured in the 80s or early 90s through an injection molding technique. We initially described 25 cases of snowflake degeneration with such lenses. This is generally a slowly progressive condition with signs and symptoms that sometimes take 10 years or more to be clinically significant. When the opacification of the lens is significant, the most common symptoms are decrease in the visual acuity and glare. This condition was classified in 4 clinical and pathological grades according to the density and severity of the lesions found within the IOL optic. These clinical, gross, and light microscopic photographs show IOLs with the grade 4 of snowflake degeneration. When the lens has this appearance, the case is usually clinically significant, requiring explantation. The most accepted hypothesis to explain the condition is that the lenses were manufactured with an excess of a molecule that's used to initiate polymerization for the formation of PMMA. With long-term exposure to ultraviolet light, there is a reaction with liberation of gas, and the lesions inside of the optic would represent mini explosions within it. Snowflake lesions are dry lesions and should be differentiated from glistenings, which are microvacuoles inside of the lens optic filled with fluid. However, in the optic area with snowflake lesions, there is usually a significant amount of water absorption, which has an impact on the clinical significance of the condition. Snowflake lesions are usually more concentrated in the central and paracentral areas of the optic of the lenses, because the periphery of the optic is usually covered by the iris, and therefore protected against UV exposure. Snowflake degeneration has not been observed in more modern PMMA lenses, manufactured through other techniques. Regarding hydrophobic acrylic lenses, we will be discussing about interlenticular opacification, glistenings, and surface light scattering due to nanoglistenings. Interlenticular opacification is the opacification between two lenses implanted inside of the capsular bag. It is usually observed with 2 hydrophobic acrylic lenses implanted in the bag via capsulorhexis with a diameter that's smaller than the diameter of the lens optic. The Acrisoft lens is the one usually affected, as the material of the lens has adhesive properties. The opacification occurs due to proliferation of residual lens epithelial cells within the interlenticular space. The composition of the opacifying material is the same as in posterior capsular opacification. To avoid this problem, besides avoiding the use of 2 hydrophobic acrylic lenses inside of the bag, you can perform a capsulorhexis with a diameter that's larger than the diameter of the lens optic, or implant one lens in the bag and one in the sulcus. When fixating a piggyback IOL in the ciliary sulcus, we cannot forget that if the lens has optic edges that are square and irregular, the lens can cause pigmentary dispersion in this location. It is always important to highlight that single-piece lenses with thick haptics, square and irregular edges, are not appropriate for sulcus fixation, as they can cause pigmentary dispersion, uveitis, increased intraocular pressure, and bleeding. Here, scanning electron microscopy shows that this single-piece hydrophobic acrylic lens has thick haptics with square and irregular edges. Glistenings are fluid-filled microvacuoles that can develop within the lens optic when the lens is in aqueous. They usually have 1 to 20 microns in diameter and can be observed throughout the optic substance. They are usually described with hydrophobic acrylic lenses, but can actually be observed with any type of lens. Here you have some clinical photographs showing glistenings with other IOL materials, but in general, they are more significant with hydrophobic acrylic lenses. Polymers used in IOL manufacture have different components, for example, monomers, chromophores, and cross-linking agents. There may be some microvoids within the polymer network. All polymers absorb water when immersed in an aqueous environment for some time, and the water absorption increases with an increase in temperature. The water absorbed by polymers is not visible, as it is in the vapor state. If an IOL is immersed in warm water and then the temperature is lowered, the water vapor inside of the polymer becomes oversaturated and detaches from the surrounding matter, gathering into the voids. As there are differences in the refractive index of the water droplets and the IOL polymer, the light will be refracted and scattered at water-polymer interfaces, which is seen as glistenings. Studies have demonstrated that a decrease of 3 degrees Celsius from body temperature can initiate the formation of glistenings. According to the available literature, the effect of glistenings on the visual function of patients is a controversial subject, with some studies showing influence on the visual function, while others show no impact at all. Intraocular lenses are very rarely explanted because of glistenings. To understand what nanoglistenings are, we can observe these two 3-piece hydrophobic acrylic lenses which are immersed in water. One of them was explanted from a cadaver eye, and the other is a never-used intraocular lens. On the left side, the light is coming from above the lenses, and they both look very similar. On the right side, the light is coming from both sides of the lenses at an angle, and the explanted lens appears whitish. Nanoglistenings are small water molecules accumulated in the subsurface of the IOL optic, as shown on the left side of the drawing. They are very different from glistenings, which are microvacuoles filled with water that are present inside of the optic substance, as shown on the right. The presence of subsurface nanoglistenings leads to an aspect of whitish discoloration of the hydrophobic acrylic lens when evaluated under a slit lamp at some specific angles. The nanoglistenings cause an increase of light scattering at the lens surface, which can be evaluated with the Scheimpflug technique, as you can see on the top photographs. However, when we measure light transmittance through the lenses, there is no difference between the control lens and the lens with subsurface nanoglistenings, as shown in the graph at the bottom. The Scheimpflug technique measures the backlight scattering. There are laboratorial techniques that can measure the forward light scattering, which is the light scattered towards the retina with a potential to have an impact on the visual function of the patient. We performed different tests with hydrophobic acrylic lenses showing subsurface nanoglistenings and demonstrated an increase in light that is scattered forward to the retina. However, the values obtained are not expected to cause any negative impact on the visual function. Therefore, IOLs are generally not explanted because of subsurface nanoglistenings. We perform the same tests with lenses explanted because of true opacification, such as hydrophilic acrylic lenses that were calcified and PMMA lenses with snowflake degeneration. The levels of light scattered forward to the retina with these lenses were significantly higher, which explained the necessity of IOL explantation in these cases. I would like to remind you that standard hydrophobic acrylic lenses usually have a water content that's less than 0.5%. There are new hydrophobic acrylic lenses in the market with higher water contents, such as the Invista with approximately 4% and the Clarion with approximately 1.5%, and laboratory and clinical studies demonstrated that these lenses are glistenings-free and also do not show subsurface nanoglistenings. In conclusion, we can really learn a lot with the laboratorial analysis of explanted intraocular lenses. Regarding postoperative opacification, different factors that may be related to the patient's associated conditions, IOL manufacture, IOL storage, adjuvants, among others, may be involved in a process leading to opacification of the lens that may be observed shortly postoperatively or even many years after surgery. There is an impact of IOL material and design on IOL complications, but we can also not forget that other factors may have a role, such as surgical technique and site of IOL fixation. With the increasing number of new IOLs introduced in the market every year, a constant vigilance is necessary. I would like to thank all, especially Dr. Chayet, for the opportunity to participate to this webinar, and thank you all very much for your attention.
Thank you very much, Liliana. That was an outstanding presentation, really, really good. We will have now a brief case presentation by our fellow, Dr. Buenomo. And then I think I personally have like maybe 10 questions for you that I would like to,
okay,
because I think you are the expert and it'll be great. It's great to have you here. So I'm sure the audience, they will have a lot of questions too. So we'll try to ask them all. Okay, go ahead, Guglielmo.
Okay, can you hear me?
yes.
Yeah. Hi to everyone. Hello to everyone. I'm Dr. Buonomo, the international fellow here. I'm from Italy. It's a great honor to be here and introduce this clinical case with Dr. Werner. Thank you. An old lady came us to for blurred vision in left eye for cataract. She underwent to scleral buckling for retinal detachment in left eye and to a phaco 8 years ago with an Alcon SN60. As you can see, the corrected distant vision for right eye was 20/25 and the left eye was 20/200. Refraction is below, but the patient didn't complain of this. At anterior segment, I didn't notice anything particular, but in the right eye, the IOL was in the bag, and I noticed something similar to glistening. I'll tell you why. Left eye had cataract, and retina was good. This is a photo from the patient with dilated pupil. Actually, I was when I started to see this patient, the pupil was very small, and you can see like this whitish yellowish appearance, and it was like this opacification of intraocular lens and something behind the lens. These are the reports from the anterior segment from anterior in CODET. This is the left eye, and this is the right eye. As you can see, there's a little hyperreflective spot on the anterior surface of IOL, and this is hyperreflective material in the back. So I was thinking, what is this? Maybe a posterior capsule opacification, or maybe a capsular fibrosis, or maybe a glistening. I was thinking of glistening because I heard a lot of surgeons, as I read a lot of articles about this complication, especially for Alcon SN60. And the second question was what to do now. Maybe observe patient, see if she complained of this, or maybe to do an explorative YAG capsulotomy, or maybe to do a lens exchange and send this IOL to Dr. Werner for analyzing, or what else? We performed a peripheral posterior YAG capsulotomy. As you can see from these reports, the fluid was better. There was only a small accumulation in the bag, and after a total posterior YAG capsulotomy, the lens was clear, and also the bag. As you can see, 2 days after the YAG capsulotomy, it was totally clear, and the uncorrected distant vision was 20/20, and also the patient reported vision improvement. Searching the literature, I found this interesting report of glistenings from Dr. Werner. The glistenings that do not correspond to the definition of glistenings. We just saw this in the webinar. In this case, the author uses the Envista Bauchelon, but in this case did not correspond to the definition of glistening because it was something similar to diabetes debris in the anterior chamber, and you can see below the resume of the definition of glistening. And it is to say that sometimes we are obsessed with an idea, but it's not the correct idea, like in this case. Because we are talking about the postoperative capsular bag distension syndrome. You can see the other nouns that you can find in literature. It's a rare complication of cataract surgery, and it happens because capsular rhexis border adheres to in the bag IOL, and such a position impairs free fluid flow through the anterior capsule. It doesn't allow the fluid to go out. I found this interesting review in the literature about all the cases reported in literature for this syndrome. These are all the symptoms reported in literature, symptomatic like the hour, to unexpected myopia, or sometimes hyperopic shift, floaters. You can find at the slit lamp posterior distant capsule or yellow-white reflex, etc. The imaging is the best imaging is from anterior OCT because it has the best wavelength of light beam to study the IOL and the posterior capsule. These images are from the image below above is from our anterior in CODET. The image below is from the article. Sham film photograph does not perform very well like the anterior segment because it has a shorter wavelength. So sometimes you can visualize the posterior capsule. UBM performs very well because demonstrate structure beyond the iris and the accumulation of fluid also in the angles of the bag. These are the most common risk factors for this syndrome, like retained ophthalmic viscoelastic devices. All the kind of devices were associated with this syndrome because they work like osmotic agents, and so trap the fluid in the bag, and the fluid can go out. Another risk factor is the inadequate cleaning for a subincisional cortex. In this case, some inflammation developed, and the osmotic pressure gradient occurs. Some studies showed us the composition of intracapsular fluid. Biochemically, you can find protein, albumin, sugar, calcium. Histologically, only fibrous tissue was shown. And with mass spectrometry, they found alpha and beta crystallines. And these are the treatment options that are reported in literature. Someone reported observation because sometimes fibrosis contraction can create a tunnel that allow fluid to outflow, but the rate resolution, the spontaneous resolution is very low. Capsulotomy is the best efficient treatment in this case, and we recommend it to do in these cases, even if sometimes it's not so easy to do because of pure pupil dilation or turbid fluid. Other treatment reported in literature are slit lamp needling and with a posterior vitrectomy, but we don't recommend this because are very dangerous for a very safe procedure like capsulotomy. Thank you. Grazie mille.
Thank you very much, Guglielmo, and so we can start with some of the questions. Please, the audience, if you have some questions, I would like to start, Liliana, with the issue of glistenings. You know, in a lot of the blogs that we are in, you know, there's a lot of surgeons pounding the Acrisov platform because of glistenings, and there's some surgeons that they say that now they do more intraocular lens exchange than cataract surgery. One of the questions I have for you, do you think glistenings will continue to be worse with time, or if the patient has already 20 years, it's enough? Because we are doing now younger patients, so I would like to hear your some of your thoughts about specifically glistenings and the Acrisov platform, and if you know if Alcon made a change in 2013. I heard that they made a change in their manufacture, that glistenings became much less than before. So,
So Arthur, can you hear me?
Yes.
Great. So first of all, great presentation by your fellow. That was a very interesting case illustrating many things, especially how important it is to do a slit lamp examination and try to figure out if any opacification is in front of the lens, inside of the lens, or behind the lens. So the case illustrates many interesting things. Regarding your question, so I mean, at least in our laboratory, we receive very, very rarely any lens explanted because of glistenings. And yes, glistenings are more frequent with the Acrisov lenses. There are studies in the literature where they follow glistenings for many years and measure light scattering and other things. Those studies appear to indicate that after some time, all of those potential micro voids within the polymers, they are filled out with fluid. And then at some point, it's going to stabilize. So that's what the studies suggest, that at some point it stabilizes. So if you give more 20 years, that's not really necessarily going to continue to have more glistenings or get worse. At least in our lab, again, we receive very rarely lenses that were explanted because of glistening. So did you mention that you are hearing about a lot of explantations because of glistenings?
Yes,
because we don't hear many.
Yeah, there's some surgeons that apparently there are surgeons who get a lot of referrals for, patients who are unhappy with lenses, and they get a lot of these lenses, but usually they claim that all these lenses that they get are mainly Acrisoft. On the other hand, we know that there's been 100 million Acrisoft or 120 million Acrisoft. So if that was a problem, I will see, like a major issue worldwide. That would be like almost like a public health really terrible scenario. And personally, pardon me? Yeah, go ahead.
So with the Acrisoft, if you look carefully on the slit lamp, I think you see it, definitely. If you look for the glistenings, you'll find it. But very rarely they are explanted because of glistenings. And again, there are studies in the literature following 1, 2, 5, 10 years. At some point, at around 2 years, it's stabilized. So it's not expected to increase too much. Subsurface nanoglistenings may increase a bit more, but at some point also it's stabilized. So you also asked about the change manufacture in 2012, and indeed that there was a manufacture change. It improved not only glistenings, but also subsurface nanoglistenings. And there is a paper published by a Japanese researcher, and is in the JCRS, I forgot the year, but he compared in clinical settings Acrisoft before 2012, 13, and after. And indeed, there was definitely an improvement. It didn't solve, you still see them, right, but it improved. Oh, yeah.
That's very good to know. There's one question by Dr. Avila. She is asking, have IOL opacifications been reported associated with intracameral antibiotics, hypotensive therapy, like bimatoprost implants, or anti-VEFG injections?
Oh, that is an excellent question. So if you remember at this, during my presentation on the calcification of hydrophilic acrylic lenses, it has been very interesting that the majority of hydrophilic acrylic lenses we are receiving in our laboratory that were explanted because of calcification are lenses that develop that localized calcification in the capsular rhexis area after some kind of secondary procedure. At the beginning, after the SAC, the MAC, procedures with intracameral injection of air, gas. But after that, we saw after anti-VEGF, intravitreal injections, or posterior segment surgeries with gas or with silicone oil. So it does not seem to be related to a substance specifically. It seems to be related to the fact that those eyes are undergoing multiple procedures. There may be some kind of subclinical inflammation, because whether you have the procedure in the anterior segment or in the posterior segment, the calcification is always, if the lens is in the back, is always in the opening of the rhexis. And that's where the IOL, the hydrophilic acrylic IOL, is in contact with the aqueous humor. So there is some change in the aqueous humor, and it's very localized. So when you explant the lens, you don't see any calcification around that. But yes, we definitely published that there are cases after intravitreal injections, yes. And the only procedure done after cataract surgery was the intravitreal injections.
Okay, now going back to optics, what do you think is what will be the long-term longevity of optics who are used to be fixated in the sclera? Like, for example, the optics used for Yamani, do you think, like the lens, it's called the...
Is the CT Lucia, and it's actually a hydrophobic acrylic lens with PVDF haptics. And it seems that those PVDF haptics do quite well. And
the haptics are I'm a little bit being abandoned are the Prolene haptics, because they were too flexible. And then if the IOL is in the bag and you have a fibrosis and contraction of the bag, those haptics will not withstand the forces, so they would decenter the IOL. I had a lot of questions about those polyimide haptics. You know, you are one of the surgeons who sent that case, to one of the cases, to us. And those haptics, after many years, they lost the elasticity. But then I heard, after our publication, I heard some other cases, but very few. So it is possible that maybe that was related to a specific batch of lenses or something, because I'm not hearing about those cases anymore. However, I never saw such loss of elasticity with the other type of haptics. But the PVDF are appropriate for the procedures with the Yamane technique and everything.
Okay, perfect. That's good to hear. Now, talking about the storage, do you think that also the more glistening seen, like in Acrisoft, is due to the storage? Can you elaborate more? Can you recommend us more or tell the public about storaging the IOLs? Because I don't think there's many surgical centers where they don't consider that.
Yeah, those cases I presented with the silicone lenses were very important, because I mean, literally there was fumigation, and that chemical component entered the lenses, contaminated the lenses, and changed the surface, and there was water entering the silicone lenses. I mean, that was very surprising. However, in terms of storage, it's really clean environment, constant temperature, dry environment. For the glistenings, the formation of glistenings is based on changes in temperature, like from a higher temperature to a lower temperature. If you get, for example, the Acrisoft lens or other hydrophobic acrylic lens, you can basically induce glistenings if you bring them to the lab and you put them in warm water, and then after some time, you change the temperature, you decrease the temperature of the water. You always induce glistenings like that. But these changes in temperature may happen in the human eye also, right? So there are studies showing that even just 3 degrees Celsius of changes may initiate glistenings formation. So it's appropriate to have storage conditions for the Acrisoft. They are, you know, for all the lenses, there are constant temperature and everything, but the glistenings initiation is mostly going to happen inside of the eye, because then the IOL is going to be hydrated. And you don't have glistenings if the IOLs are not fully hydrated. And then they are hydrated, there is a change in temperature somehow, and that process initiate. But in any way, the conditions of storage are important, right, for all IOL. There are very interesting cases published, and this is with hydrophilic acrylic lenses. The lenses were stored, or they are coming, and the temperature coming outside of the building, and the temperature was very, very low, like it was snowing or something. And the packages went directly to the OR, and the lenses were implanted, and within 1 hour, the lenses were white inside of the eye. And then with equilibrium of temperature, actually that opacification disappeared. So even with hydrophilic acrylic lenses, if you have a huge change in temperature very fast, you may have an opacification inside of the eye, but in that case, that's reversible. But it can be very impressive.
Right. No, I think we saw that with some of the size lenses, probably in places where the air conditioning in the operating room was too cold. And then when the lens went into the eye, immediately it opacified. We didn't see it, but we heard some
Interesting.
We heard some stories about it. Let me switch.
Yeah, there are some publications.
Yes. Let me switch a little bit. I'm very intrigued. I know that you, at your lab, you have been using like Miyake cameras to see what's going on at the sonule level. Can you tell us what have you seen in terms when we do cataract surgery, on eventual cataract surgery? I mean, are we damaging the sonule just by some of the movements inside the eye? what can you tell us about?
You know, yeah, I think there are some Miyake Apple videos available of experimental surgery, and it would be great for any surgeon doing cataract surgery to actually visualize the cataract surgery via the Miyake view, because you can be very surprised by how much you move the bag and how much you stretch the zonules during certain maneuvers, like when you rotate the nucleus. And that can be very impressive. Even when you put like a capsular tension ring, depending on how you put it, you may even create some damage to the zonules if you don't put in the appropriate direction. So I would advise any surgeon to actually check a cataract surgery via the posterior view, because you can learn so much, because all of those regions are hidden via the anterior view. You cannot see that. So you may not be aware of what kind of distortion of the zonules and the bag you are doing. So it's a great learning experience, actually.
Yeah, I'm worried that these days surgeons are doing surgery to younger patients more and more, and the life expectancy of humans, it's going, you know, longer.
Yeah, it's increasing, right? Yeah, yeah.
So for example, I think that currently the longevity of IOLs is around 20 years. That's what we've seen. I mean, it's rare to see somebody with more than 20 years of having an IOL implanted. So the question
Unless
is,
a pediatric case or something.
yes, yes. And I've talked to pediatric surgeons, but they lost those patients because once they become adults, they go elsewhere. So the pediatric surgeons, they are losing that information. So I'm worried. I mean, what can we expect of 40 years of an IOL in terms of clarity, in terms of the back stability? What have you seen in your lab about it?
Definitely the in the bag IOL dislocation, it's just increasing. I mean, we have so many specimens in our laboratory. It's very impressive. We publish a lot about that. And as the patient age, I mean, with age, definitely there is an increase in the bag dislocation. And we did very interesting studies, for example, with the specimens from Germany, because there, they actually, when there is in the bag dislocation, they like to remove the whole bag and the IOL, and they like to put the iris claw lens, you know, on the posterior surface of the iris. Whereas here in the United States, quite frequently surgeons like to refixate everything. So we get a lot of specimens from Germany. We published a very interesting case. As you know, of course, one of the most important causes of in the bag IOL dislocation is pseudoexfoliation because of zonular weakness and everything. And we got, for example, I think it was like 40 in the bag dislocated IOL, so the IOL inside of the bag. And we performed histopathology in all of them. And we collected a questionnaire from the surgeon and the ophthalmology describing which cases they thought there was pseudoexfoliation. And it was very interesting because they said there are 13 out of 40 with pseudoexfoliation. When you do histopathology, we found 26. Therefore, what happens is that pseudoexfoliation may be much more common than what we think. And that's a very important cause of zonular weakness. But you're right, the in the bag dislocation problem, it's increasing. Yeah, and it increases with age. There is no doubt.
And my fear is that, for example, if you do cataract surgery to a 50-year-old, that is gonna be very active, you know, doing a lot of exercise, running, and things like that. What is that the impact? I mean, we don't know. I mean, when patients act, we don't know what's, you know, it's very different to cataract surgery in the 90s. So now,
which was later in the lifetime. So and definitely each year in the laboratory we have more and more in the bag IOL dislocated specimens. So that's definitely increasing.
Right. So you think, I mean, I think the rate is also higher because of one piece in the bag IOLs as compared to in the 80s or 90s when?
That I'm not sure, Arturo, because actually when we look at it in all the specimens we have, all the IOLs are represented. Single piece, 3-piece, silicone, PMMA, hydrophobic acrylic. And at some point I thought maybe these are the specimens with a lot of Sommer's rings, so the whole bag is very heavy or something, but it can be anything, a lot of Sommer's ring, not match, a lot of fibrosis or not match. So many things are represented. So this we could not really demonstrate, at least for the moment, that there is a preference for a certain type of intraocular lenses.
Would you recommend for pseudo-exfoliation for surgeons to use like a 3-piece IOL, put it in the sulcus with maybe a optic capture into the back?
It's interesting because there are some papers where the surgeons were doing that. And then my question for those was, okay, what happens then with the capsule and the posterior capsule opacification and everything? So whenever I talk to surgeons, they had like a small follow-up. I don't know what happened in the long term. I thought maybe there would be a lot of Sommer's ring formation, posterior capsule opacification and everything, but I don't know any long-term study. I would expect that that would be a lot of opacification there, but I don't know any study that's really long-term.
Very good. If anybody has more questions, I have one more question.
Sure.
For retina surgeons, they appear to be using a lot of hydrophilic scleral fixating IOLs.
Mm-hmm.
I don't understand why they like more to use hydrophilic instead of hydrophobic. If there's nothing for them to use like gas and silicone.
Yes. It's actually interesting that you asked that. So my next editorial of the JCRS, I'm going to talk about sclerofixation and some issues with specific lenses. But I know that one of the favorite lenses that people were using to do sclerofixation was the Acryls by Bachelon, because they liked it has the 4 closed loops.
Right.
And then they suture that with whatever suture, and there are 4 points of fixation. So they consider that's actually good for, you know, no tilt or decentration or anything. So that technique was getting very popular until exactly what you said happened. The lenses started to calcify.
Okay.
And we received many in our laboratories, because those are eyes that, if you think, are undergoing secondary procedures. And we received quite a few already that were explanted after sclerofixation, because they are hydrophilic acrylic. And I think 2 years ago, maybe, one of the retina, one of these magazines that it's for ophthalmology, but it was specializing retina, they asked me to write a paper about lenses and retina surgery and everything. And one of the things that I commented is that we are seeing calcification, that form of localized calcification of hydrophilic acrylic lenses after procedures, even in the posterior segment. And even the procedures in the posterior segment is the anterior surface that's calcified within the rhexis, and is a very dense calcification, and the lens end up being explanted. I do not know the rate of that problem. However, if you consider the situation with the MAC or the SEC, 10% of those lenses may calcify. So that is quite a lot in an eye that's already a bit complicated, right? You do cataract surgery, you already have to do a corneal procedure, and that's an eye that's already challenging. And then after, you have to explant the lens because the lens is calcified. I don't know after the retinal procedures if it's also 10%. But in any way, we receive a lot in our laboratory from everywhere in the world with that central calcification after retina surgery or after the MAC, any secondary procedure, even just the intravitreal injections, as we discussed.
Regarding the lens gen base that you just published 2 months ago in the Journal of Cataract and
Sure. Mm-hmm.
We have used that lens here in clinical trials, and we are very
clinical trials. Yeah. Oh, interesting. Yeah.
Very impressed with the no PCO effect that you mentioned. So, do you think that there will be a trend for like capsular field bags, IOLs in the future?
Yeah. So we published a few years ago a review article with the JCRS about intraocular lenses that have a special designs that keep the bag expanded and open.
Right.
And at least in our rabbit studies, I mean, the rabbit model is accelerated in terms of PCO. So with 4 weeks, we can see the equivalent of PCO in more than 2 years in the human eye. That Lenggen paper we published was a 6-month rabbit study, and we score PCO in those eyes as 0. I never saw that in a rabbit eye. I just never saw it. It was the very first time. But we saw with other designs, like there was a lens named Anil, Zephyr from the company named Anil that we tested also and we published. It was a round lens, also keeping the bag very open. And again, 6-month study, PCO practically speaking 0. So there is something about keeping the bag open and having the aqueous humor going around and rinsing everything. It's really very different. So at least in the rabbit eye, the behavior is totally different from a standard lens. So in the rabbit eye with a standard, let us say single piece acrysoph, for example, at 6 months, it's like the lens, the crystalline lens is there again. There is so much PCO that the intraocular lens is like buried inside of that proliferative material. That's what's normally happening. And with the other lens, we scored a 0. So it's very impressive.
Yes. Now, with the light adjustable, the light adjustable lens, we've been implanting it for the last 20 years, and the lens remains clear. It's a silicone lens. What do you think about that material and why it has remained clear until now? We haven't seen any opacifications, but I don't know if we will see or not, because...
So you are talking about opacifications of the lens itself or the capsule?
No, the lens. I mean, like,
the lens itself.
Changes in the clarity
Yeah.
of the adjustable lens.
Yeah, I never heard of any other issue with that material. We did all the preclinical studies in rabbit models with that lens. And also in our follow-up, we didn't see any issue with opacification, even after the light adjustment or the lock-in procedures and everything. So far, I never heard of any specific issue with that material.
So, yeah, but I mean, the question was because you were mentioning about changes in some of the silicone IOLs, but I guess it was a different type of silicone. I don't know.
Oh yeah. So I mentioned about 2 things. One was calcification, but that happens in eyes with asteroid hyalosis in the vitreous. You have the calcification on the posterior surface. That happens with any silicone lens. And another thing that I mentioned was those cases from Brazil, but those lenses were stored in a location where there was fumigation. Those lenses got contaminated with some chemical and the whole surface changes and water start entering. That's what happened. So that was a very specific problem.
Okay, very interesting. I mean, we actually learned a lot, and thank you so much for all the work that you are doing with also with Dr. Mamalis, and I still remember with a lot of Dr. Apple.
And you came to visit us one time, right? I think to do some studies, and I remember that.
Yes, and David Apple, when I was a fellow, he came to UCSD to lecture, and I asked him, would you go to Mexico? And he after that meeting, he went to Mexico, and
oh, great! Yeah,
and he was a great person, and
he was a great speaker, and he definitely went everywhere for sure. And Nick Mamalis and myself were both his fellows also at one point or another, and very grateful to him for him to have started this work, which we are very, very happy and proud and honored to continue. It's a very important work.
And intraocular lenses are on the rise. I mean, 30 million, or I don't know how many will be implanted, but that's the most performed procedure.
Yeah, so, in the world. Yeah.
So we need all your work to make sure that we are not creating a monster that IOLs are that So, thank you so much for, seeing all this from a laboratorial point of view.
And again, I mean, if any of you in your department, if you have any interesting case, you do an explantation, we'll be very happy to analyze the lenses.
Any surgeon can send you, I mean, no matter.
Absolutely, yeah. We receive from everywhere in the world, and we always take a look, at least a macroscopic and microscopic look. We will always do it. And
what's the process? They just should send you in which conditions you want the
What I like to do is that the person communicate with me by email first and give a brief summary of what it is, because depending if it's just the lens, it is actually easier to just send the lens in the dry state instead of sending in some liquid that can get contaminated with fungus or something like that. Right. If the lens is, of course, explanted like within the capsule bag, then there is tissue, then the best procedure would be to put in like formalin or something like that. Okay. And we always like to receive some kind of summary, what happened, why you explanted and everything. And once you receive in the lab, we'll definitely send at least a preliminary report. So definitely at any time.
Is there a cost for the surgeon to send you these lenses?
If there are what costs?
Yeah, is there a cost for the, I mean,
we will not charge anything for the analysis of light microscopy, the basic analysis that in the majority of the cases, we will answer the questions. We don't charge absolutely anything. You have costs, of course, of sending to us. But of course, if we have cases where, let us say, some special analyses are necessary or something, there may be costs. However, let us say those are so interesting that we want to publish. We will find grants to cover those costs, and we will manage that everybody's a co-author and everything, like we did with your case and everything. So, yeah, even if it's a very interesting case and we need to do special analysis, but if it gets very interesting, we will have grants to cover. But the basic analysis, we don't charge anything.
Great, that's even better work from you guys. So thank you so much, Liliana.
Thank you.
Being here so late, and we really appreciate it. And in the name of all our colleagues here at CODET and everybody who attended the webinar, we had a very good attendance. So thank you again. It was a really good presentation.
Thank you very much again for the invitation. I really appreciate it. And thank you for the presentation of your case, Dr. Bonomo. It was very interesting. So just to let you know that I'm also Italian. My family came from Italy. I have an Italian passport too.
Very good to know.
I don't speak Italian, unfortunately, but I have an Italian passport.
Thank you, Dr. Werner. Thank you, Dr. Chayet, to invite me. It's a very great honor to me to be here and discuss with you of this case. Thank you.
Thank you.
Okay,
bye-bye.
Bye-bye, everybody.
Bye.
Bye-bye.